Today we're going to be looking at adrenal insufficiency, focusing on Addison's disease and secondary causes. Before looking at the condition in question, it's important to review the structure and functions of the adrenal glands. So if you remember, our adrenal glands sit on top of our kidneys, and we can zoom in to see the different layers of each adrenal gland. The topmost layer is called the zona glomerulosa, and this is responsible for secreting mineralocorticoids like aldosterone. The second layer is called the zona fasciculata, and this produces glucocorticoids like cortisol. The third layer down is called the zona reticularis, and this secretes androgens or sex hormones. And then the final inner layer is called the adrenal medulla, and this produces catecholamines like adrenaline. For the purposes of this video, we're mainly going to be focusing on the topmost layers, as these can be affected in Addison's disease. Another aspect to review is the hypothalamus-pituitary-adrenals axis. So what happens here is that we start off with the hypothalamus, and this secretes a substance called CRH, or corticotropin-releasing hormone. This CRH then acts on the anterior pituitary gland, triggering it to release ACTH. This ACTH then acts on the adrenal glands, triggering the release of three key hormones: aldosterone and other mineralocorticoids, cortisol and other glucocorticoids, and androgens. And it's important to note that this entire process is governed by a negative feedback system. So as the levels of cortisol go up, it should feed back on the system to reduce levels of ACTH and CRH in the system. And this helps to keep the whole process in check. Okay, so turning towards the condition itself, adrenal insufficiency can be defined as a reduction of the adrenal hormones in the blood. And the best way of thinking about this is that something can go wrong with each stage of the HPA axis to cause adrenal insufficiency. For example, there could be a pituitary tumor, which causes the anterior pituitary gland to release less ACTH, and that decreases cortisol further down the axis. There could also be a condition known as Sheehan syndrome, which affects women after childbirth, where the hormone output of the anterior pituitary gland decreases significantly. Alternatively, there could be problems directly with the adrenal glands themselves, such as autoimmune factors, infections such as tuberculosis, or adrenal tumors. And just to show how this works, either autoimmune factors or infection results in the layers of the adrenal glands being affected. And note how the topmost layers, the zona glomerulosa and the zona fasciculata, are most likely to be affected as they're near the top. And this results in a decreased aldosterone and cortisol output. Finally, abruptly stopping steroid treatment can also have an impact on these hormones. Note that the most common cause of primary adrenal insufficiency, so where there's a problem with the adrenal glands, is autoimmune factors in developed countries. Adrenal insufficiency can have multiple impacts on the body, including electrolyte changes. To work out these changes, we can look at what aldosterone normally does within the body and extrapolate to see what would happen if there's insufficient aldosterone present. So just as a quick recap, aldosterone has multiple effects, including sodium reabsorption, where sodium ions enter the blood from the renal ducts, water reabsorption, where H2O follows sodium down a concentration gradient, and increased potassium excretion, where potassium ions leave the blood and enter the renal ducts for excretion in the urine. In adrenal insufficiency, there's less aldosterone present in the blood, which results in all of these effects being diminished. So for example, there's reduced sodium reabsorption, which can result in hyponatremia, as there are fewer sodium ions present in the blood. There's also less water reabsorption, which can result in hypotension or dehydration symptoms. And there's also reduced potassium excretion, which can result in hyperkalemia. And it's important to remember this triad of electrolyte changes, as it helps with the diagnosis of adrenal insufficiency. As well as this triad, adrenal insufficiency involves reduced levels of cortisol as well as reduced aldosterone, which can result in an array of other symptoms. For example, there could be low mood and fatigue, as well as dizziness and fainting, related to the hypotension or to reduced cortisol levels. There could also be loss of appetite and weight loss as a result of this too. Other changes include muscle weakness and skin changes, and more specifically, the skin changes involve hyperpigmentation, where regions of skin become darker and this can also affect the gum line as well. Note that if these skin changes occur, they're only seen in primary adrenal insufficiency, so when there's a problem with the adrenal glands themselves, and this occurs due to increased ACTH levels. For the diagnosis of adrenal insufficiency, a good place to start is with the morning serum cortisol and serum ACTH levels. And the reason why these have to be conducted in the morning is that cortisol has a diurnal variation, where levels vary throughout the day, so it's important to have a consistent measurement. Just to interpret these results, you can see that if the morning serum cortisol levels are reduced, but the serum ACTH levels are increased, it suggests a primary problem or an Addison's disease at play. And this is because ACTH is trying to increase and stimulate the adrenal glands to release cortisol, but there's a problem there, and for that reason cortisol levels remain reduced. Alternatively, if serum cortisol is reduced and ACTH levels are also reduced, it suggests that there's a problem higher up the axis, and it's important to investigate for secondary causes at this point. Other investigations include electrolytes and blood pressure measurement to look for the triad of hyponatremia, hyperkalemia, and hypotension. To confirm the diagnosis, the short synacthen test can be performed, and I'll discuss this in more detail in the next slide. It's also important to look at other investigations, such as routine bloods, autoantibody testing, and imaging if required. Okay, so moving on to the short synacthen test, we have our normal HPA axis here, and we administer synacthen to the patient and measure the levels of cortisol before and after the test. Note that the name synacthen actually tells its function as well. It's simply synthetic ACTH. So when we administer synacthen to the patient, the levels of ACTH should go up, and the levels of cortisol should go up correspondingly. This is a normal test result. If we now compare this to a primary adrenal insufficiency, you can see on this axis that there's a problem with the adrenal cortex, and the levels of cortisol are lower than normal. If we administer synacthen in this case, the ACTH levels go up, but the cortisol remains low, and this is because the problem is below the level of ACTH in the axis, so administering more synacthen or more ACTH does not have any effect. If we also look at secondary causes such as pituitary insufficiency, here there's a problem with the anterior pituitary gland, and you can see that less ACTH than normal is being produced. So when we administer synacthen in this case, the ACTH levels go up, and the cortisol levels also go up correspondingly. In other words, we can distinguish between a primary and secondary cause using the short synacthen test. If the cortisol remains low after the test, it suggests a primary cause, and if it increases after the test, it suggests a secondary cause. Once a diagnosis of adrenal insufficiency has been made, it's important to manage the condition for the patient, and the mainstay involves adrenal hormone replacement. Low levels of cortisol can be replaced using hydrocortisone or prednisolone tablets, while low levels of aldosterone can be replaced with fludrocortisone tablets. Notably, it's important to increase replacement doses of these medications before surgery and during infections to prevent any adverse effects. And one of these adverse effects might be an Addisonian crisis, which basically involves a sudden worsening of symptoms in these patients, usually triggered by stress or an infection. And you can see some of the signs and symptoms which can occur in the diagram here. To manage an Addisonian crisis, we can give IV sodium chloride for fluid balance, IV hydrocortisone to replace the cortisol levels, and IV antibiotics if there's an infection present. Okay, to finish off, we have a quick clinical case here. A 37-year-old female presents to general practice with fatigue, muscle weakness, and low mood. On examination, she's noted to have areas of skin hyperpigmentation. Given this presentation, which electrolyte changes may be seen in this patient? So from the stem, you can see that this patient might be presenting with adrenal insufficiency, and the common electrolyte changes here are hyponatremia and hyperkalemia due to reduced levels of aldosterone in the blood. As a follow-up question, the patient is referred for the short synacthen test. What is the most likely diagnosis based on these results? So from this table, you can see that the pre-test cortisol is below normal limits, and the post-test cortisol does not seem to be influenced by synacthen. And based on this, we can say that this is most likely a primary adrenal insufficiency or Addison's disease, because synacthen had no significant effect on increasing the serum cortisol levels. If, on the other hand, synacthen did have an effect, the main differential would in fact be a secondary cause of adrenal insufficiency. Here is a summary slide explaining everything I've gone through in the video. If you have any questions, please leave them in the comments, and I'll see you in the next video.